I'll give you some reasons as to why I think that LGH is a useful finding in clinical practice. Now this is one of our patients, and this is the LGH that is described in the ICG late frames, where you see geographic hyperfluorescence. It may or may not actually correspond to the earlier BVNs. As you can see in this example here, one of the lesions you can see is corresponding to the BVN, this lesion. The other one does not really correspond to a well-defined BVN. And he also covered this slide where he talked about LGH being predominantly in patients with PCV patients. And in around 8% of AMD eyes, Kang et al. Showed that LGH could exist. This is a point that he did make a passing mention, that LGH is pretty much more obvious on CSLO images when you compare it with fundus photography image, and that's probably why we were not seeing LGH before, and probably we are not taking late frames, ICG frames enough. We're not looking at the late frames because to diagnose PCV, we look at the early frames most of the time, and that's probably why we are not identifying LGH in practice. Now, LGH, does it change over time? He mentioned the fact that Kang reported that nearly in 50% of eyes it increases over 1 year, but it does not regress spontaneously. Now, this is an example of ours where this is a patient with typical PCV, and you see the late frames showing the LGH. Now, LGH can have variable hyperfluorescence. As you can see, there's a polyp which is little more hyperfluorescent than the branching vascular network. You can also see the hypo, the PED. And this is the OCT through the lesion. This patient actually underwent combination therapy, and following that he received four injections of anti-VEGF, and this is like almost at 1 year. You see the character of the LGH has changed. So the size and the character of the LGH, if it changes, it probably means something. This patient had quiescent disease, and during the next 6 months of follow-up, he is now followed up for 6 months, he has not had a recurrence. So this may be one of our lucky patients. And there are studies, as he said, Kang et al. Has clearly showed that as compared to eyes demonstrating persistent LGH after PDT, the eyes with fading or disappearing LGH evidence a lower recurrence of active PCV. Consider this example. This is a patient with AMD, it is not PCV, AMD, where you have this large LGH that you see here in the region. And this actually progressively increased over 3 years of follow-up. You can see the LGH occupying almost the whole of the foveal region. And so this is an LGH which is increasing and persistent, and this is the end result. We had this multi-layered PED. Patient is continuing to receive anti-VEGF injections. So this is an example where persistence of LGH led to persistence of the disease. And in fact, Oban et al. Had reported quite early that well-demarcated hyperfluorescence with late ICG leakage could be a reason why many of these patients have poor visual outcomes and poor anatomical results in patients with typical AMD. So it matters even in typical AMDs. Now consider this example. This is a patient who had LGH at baseline. This patient had peripapillary LGH and had nothing in the macula to start with. And over a period of time, around 13 months, you see the character of the LGH has changed and the size has increased, and this heralded the onset of a macular disease. So it is possible that peripapillary LGH increase is a predictor of macular disease in at least certain situations. This example here is a patient with typical PCV in one eye. If you look at the other eye, he had an LGH in the other eye. And if you look at the OCT, there is nothing in the OCT to show a double layer sign or any active PEDs. So this patient probably is an indication that LGH could be a precursor for PCV lesions. And there are studies, as Dr. Rajesh said, Hang et al. Has shown that nearly 25% of his patients had LGH in the other eye, and nearly 1/3 of these eyes went on to develop PCVs during follow-up. And they believe that the LGH was larger than the BVN. Kim et al. Believe that LGH is larger than the BVN in almost 40% of patients with PCVs that they described. And Kang had reports that this could be an effect of choroidal telangiectasia. They don't believe that it's part of the branching vascular network. They believe that some other process that is involved in these patients, and they call it choroidal telangiectasia, which could be secondary to the hypertensive insult that these patients have. And look at this example. This is a patient where you see the polyps, you see the BVN, and if you have to use the Everest guidelines, you probably would be treating these lesions. But if you look at the LGH, you see this is a pretty large lesion here. And if you pass the OCT to these lesions, you can see the double layer sign and the diffuse PED. So probably if LGH is probably a better indicator in certain situations. It may be better than early ICG changes when managing PCV, especially if you are planning something like combination therapy with PDT. So I feel that demonstration of LGH is a useful sign. It helps in diagnosis, as Kang et al. Had said that it should be a part of the diagnostic criteria, and it helps to identify good responders. And extrafoveal LGH may be a marker for macular disease, and it makes sense to involve this in planning PDT. Thank you.